Hi, I'm Jack Mulvey, and I'm here with Capital Community. We're very fortunate today in that we have Dr. John Bennett, who is the President and Chief Executive Officer of Capital District Physicians Health Plans. And he's with us to talk about health insurance, to talk about who he is and where he came from, and to give us some idea of what's going on in the healthcare business, not only from an insurance perspective, but also from the perspective of how we as citizens and as healthcare users can get a better feel for what's actually happening out there with all the various and sundry people waving flags and telling us how everything's falling apart. Perhaps we can find out that things will make progress and we'll go ahead. So welcome, John.
Thank you.
When we talked a little bit earlier, you told me you were from Brooklyn?
Yes.
Grew up in Brooklyn?
I did.
Did you stay there right through going to college? Or?
Yeah, through high school. I grew up in Flatbush and Canarsie and went to the New York City public school system through high school.
Did you? What,
Yep.
what particular high school did you go to then?
Went to Canarsie High School,
Canarsie.
which actually I found out closed not too long ago.
Yeah, it's a sad thing.
It is sad. It was a great school at that time, and we had a great time. I had great teachers, and sadly it closed.
It becomes part of who we are when we look back at
Yep.
things like that. It's
Yep.
a major portion of who we become.
That's right.
When you left there, where'd you go? Where'd you go to college?
I went to RPI. I came to Troy.
Did you?
I thought I wanted to be a chemical engineer.
Mm-hmm.
I like chemistry, I like math, and I put them together and decided I want to be a chemical engineer. So I looked around and found RPI, and I came to Troy to do that.
When you were there, what type of coursework did you take?
You know, I started out in the traditional engineering program at RPI.
Mm-hmm.
Did 2 years of the engineering curriculum before I decided that I wanted to be a doctor, and then switched into biology. So ultimately, my degree was in biology and pre-med. But I took the basic engineering courses and enjoyed them. I still like to read some of that techie stuff.
What made you decide that you wanted to become a doctor?
I think it was, I had to do an elective in community service,
Mm-hmm.
and I started going to a local emergency room. It was at Samaritan Hospital in Troy.
Right near the campus, right?
Right there. And I remember I would walk over there and spend time in the emergency room, and I really started to admire the doctors in the emergency room and really started to question what I wanted to do. And thought that, you know, as I saw people graduating in engineering, they went into the business world, and I said, you know, I'm not sure that's for me, and really just fell in love with medicine there in the emergency room.
So you spent 4 years at RPI, graduated. Where did you end up going to medical school?
I went back to Brooklyn, actually, and went to State University in New York, Downstate Medical Center, which, interestingly, the Downstate campus was actually literally around the corner from the house I lived in right after I was born, right near Kings County Hospital. And the dorms that I moved into were on land that my great-grandfather had actually, a little plot of land that he had actually owned many, many years ago, which was kind of funny. But so I went back to Brooklyn for 4 years.
Well, that's terrific.
Yeah.
And then from there you went where?
Then I came back because while I was at RPI, I met my wife. She's from North Greenbush, DeFriesville, and she was at Russell Sage, and she's a physical therapy major, and we met in college, and we got married in the middle of my medical school. And I always knew I wasn't really going to stay in New York City. It just wasn't for me, and then we came back here, and I did my training at the Albany Medical Center.
So when you say training, you're talking about your internships
Right.
and your
Yep.
residency?
Yep. I did an internship and a residency in internal medicine, and then did cardiology fellowship.
At the medical center?
All at Albany Med, yeah. Yeah. And then just stayed on in practice here in town.
So you became a cardiologist.
I did.
And how many years did you spend doing that?
Well, training was a total of 5 years.
Mm-hmm.
So internal, now it's actually a little longer. Now, at that time, it was 3 years of internal medicine and 2 years of cardiology. I actually did 2.5 and 2.5 because at the end of my fellowship they needed some extra help in the cardiology division, and I kind of transitioned earlier. Now, of course, it's 3 years minimum of cardiology fellowship, but then it was 2. So I did 5 years in training.
So now you're probably about 30 years old, 32 years old, something like that.
Yeah, I was actually, believe it or not, I was actually 29 when I finished training. I graduated high school, I was 16.
A baby.
Yeah, so, because I was a November baby, and then in those days you didn't start kids late, you just went when you went. And then they skipped.
Whenever your mother wanted to get rid of you,
That's
you went
right,
to school.
she wanted to get rid of me. And then they skipped me a grade. I was in PS 114 in Brooklyn, and you know, the baby boomers, there was a lot of kids in the city, and I think they had space problems, and they put me in a class of combined second and third grade, and then they did this experiment, and at the end of second grade, I went on to fourth with about half the kids that had done that. So I was only 16, which never really hurt me. It certainly didn't hurt me academically, but I'm not so sure it was the best thing to do from a social perspective.
They keep doing those things sometimes.
Yeah, it was a little rough when I was in high school from a social perspective because I was young. I was young.
And a year back then is a lot different than a year now.
Yeah, and I was a little kid, and but it worked out.
You seem to have suffered through all
I think I made up for it. I think I did it right. Yeah.
So now you're out in practice, and you practiced for how many years before?
I practiced. So I went into practice in 1983, and so that was, and I left in 2008. So that's 25 years, 25 solid years of practice.
And how much change did you see over the period of time, that 25 years, from coming out as a cardiologist, fresh from medical school and fresh from the specialization residency program you have, and now 25 years later, how much change has there been in the business? The
change was enormous. I mean, from a scientific and treatment standpoint. I mean, I remember my first rotation as an intern in 1978 was, at that time, the Albany Medical Center internal medicine residency program used St. Peter's Hospital a lot. And my first rotation was in the coronary care unit at St. Peter's Hospital. And at that time, when you had a myocardial infarction, which is a heart attack.
Blockage of one of the arteries.
Blockage of one of the arteries, which what we didn't know at that time was that it was a sudden total blockage for a full thickness heart attack. But when you had one, basically there was no treatment. I remember we would round on the patient several times a day. We would basically give them morphine for pain and occasionally some nitroglycerin and basically watch them. And frankly, you know, whether they survived or not was not so much based on anything we could do. And the mortality, of course, of an acute myocardial infarction at that time was 30%. Wow. 1 in 3 people that had a heart attack in 1978 died. And of course, you stayed in the hospital for weeks. At that time, we were getting aggressive, and you only stayed in the hospital for 2 or 3 weeks, as opposed to the 4 to 6 weeks that had been several years earlier. And of course, you were on bed rest, which we now know is the worst thing. It leads to more blood clots and more death. But so the mortality was 30%. And by the time I finished my career, 25 years later, we were treating heart attacks by taking people immediately to the cardiac catheterization laboratory and opening up the arteries. And of course, the mortality of acute myocardial infarction dropped to below 5%. This is a phenomenal improvement.
Now, myocardial infarction really is the death of part of the muscle in the heart, isn't it?
Yes. Yeah.
And so it's caused by a lack of oxygen?
Yeah, a lack of blood flow. So there's especially when there's a sudden cutoff, the heart really can't adapt to that. And when there's a sudden cutoff that's due to an atherosclerotic plaque that ruptures or forms a clot on it, that part of the heart muscle dies. And of course, the heart no longer can pump effectively. But just think of that, the mortality that, I mean, people used to, 1 out of 3 people.
30% to what?
To 3.
3.
I mean, in 25 years or less. That's phenomenal.
And actually, the medical center has an outstanding program. Isn't it one of the better programs in the state or in the country?
Yeah, I think we're very fortunate in this area that our cardiovascular programs at really, at the Albany Medical Center, at St. Peter's, and also at Ellis, which also does work, are all high-quality programs. And the New York State has really been at the vanguard of tracking quality in cardiovascular programs. And some of the people locally that have done that work at the SUNY School of Public Health have really done groundbreaking work on helping New York State track quality. And the quality in our programs in this region are really, really very, very good.
When we say track quality, what are we trying to say to people? How do you understand tracking quality?
Tracking quality in cardiovascular disease, now you can go on the New York State Department of Health website and find the risk-adjusted mortality statistics for your heart surgeon that you are interested in, or your cardiologist who's going to do your angioplasty. And it's statistically valid work, and you can find the relative risk-adjusted mortality and complication rates of your surgeon or cardiologist. And I think we've made great strides in this area in general in keeping up and doing very, very good work.
So you continued on, you became part of the cardiology practice here in Albany.
Yes.
And you ended up, at one point in time, active in CDPHP, were you?
Yep. Yeah, well, I was, practicing, and of course we were growing the practice, and, the practice ended up with over 20 cardiologists, and then, of course, we then broadened the practice even more, and the practice then had some internists and had some radiologists and some hospitalists, so it became a very large multi-specialty group. But in the middle of that, somehow I know how it happened. I got involved with CDPHP in 1996. Yeah. And that's when I was appointed to the board.
So you were on the board of CDPHP.
Yep.
Dr. Bill Colonie was the, I think, president or chief executive at some point during that time, wasn't he?
No, Bill was actually, when Bill was in Albany at the Albany Medical College in urology, Bill was one of the original kind of founders. He was on the first board, I think.
Okay.
And of course, our founder.
Now you guys were a not-for-profit.
CDPHP is not-for-profit.
Okay.
Yep. And I can tell the story about the founding. Our founder really was a man named Dr. Jack Carter, and Jack was a local, very prominent surgeon in private practice, very big practice at the Albany Medical Center in St. Peter's. He really, he was a very well-known guy, great guy, and he founded. He really was the driving force. He, and also at that time, Dr. Anthony Tartaglia, who was a prominent hematologist, later became dean of the medical college. They got together, the docs, and they wanted to form a health plan that could make sure that they kept the practicing doctors involved in major decisions in the insurance world and in medical care, because they were concerned that as things would evolve, that whether it be business forces or the government would begin to lessen the ability of doctors to really control what was going on with their patients.
Have input.
Yeah, to have input. And so they formed a not-for-profit HMO at the time, and CDPHP was purely an HMO.
Health maintenance organization.
A health maintenance organization, and did not sell traditional insurance, only sold an HMO. And there's a difference between insurance, as defined by New York State, and an HMO. And that involves a lot of things, not the least of which is community rating, which a lot of people don't understand in the healthcare debate. But anyway, so Jack and others formed this company in 1984. They got approval from the then head of the Commissioner of Health, which was Dr. David Axelrod, who was really another legendary figure in this area. And they took $1,000 from 500 or so doctors. And that was my first full year in practice, and I didn't have $1,000. But fortunately, my partners at the time, Dr. Robert Rosenthal and Dr. Ramon Fabregas, gave me $1,000 to make the contribution. And so I was one of the corporate A members, or the original corporate members. And then the plan just kind of grew, in the late 80s. The plan really had some struggles. It's hard to grow an insurance company, obviously, or even an HMO at that time. You start off with very few members, and people tell stories about, them waiting for the fax machine. They would collect the premiums, and of course, when you have a very small membership, if you have one very sick patient, you could be bankrupt in a heartbeat. And they would, say, "Oh my God, is someone going to have some terrible thing, and we're gonna be done."
Risk management.
Risk management, and but the plan slowly but steadily grew, and my involvement was really minimal at the beginning, until about 1995 or 1996, when I began to attend some of the meetings, and I actually, because the meetings were usually very active, the doctors all would debate different things, and I started to take a more aggressive role in debating. And at one kind of crucial point in the debate where a major vote was being taken, I remember the night very well. I was very tired. I'd been up all night before. It was late, and I made an impassioned speech about the plan. And after that, and it kind of settled the meeting down. And after that, Jack, at the time, our board was appointed by itself. Now they're voted on by the doctors. And Jack basically would pick who he wanted. And after that speech, I'll never forget it, I saw Jack in the hallway at St. Peter's Hospital. He looked at me and he said, "Bennett, right?" I said, "Yeah." And he said, "Come here." He says, "Would you like to be on the board?" And I said, "Wow, okay." You didn't say no to Jack Carter. And I said, "Sure." And so that started my path with CDPHP.
Terrific. Now, how did you transition during this period of time from being on the board to be more active, perhaps, in the management of the company? Give me a little idea about that.
Sure. Well, I started out, kind of slowly, obviously, but the way I do things, when I do something, I do it. I tend to really do it, or I don't get involved in it. So I was always kind of a numbers guy, being a kind of a math kid and engineer. So I was always kind of good with numbers, and so they put me on the finance committee. The finance committee on a board is usually where a lot happens. And so I started to learn, and I would come to the meetings every month, and I found myself being fascinated with this whole insurance and risk and all this stuff, and how they set premiums. I just found it fascinating, and I started to really study it. So I would spend, we'd have a board meeting, let's say on a Monday night, and I found myself, really pouring through the financials and really trying to study it. And so I got involved in the finance committee. And then as a result of that work, when there was an opening, Jack put me on the executive committee. And then before I knew it, I was vice chair. And then that was, after Jack suddenly died. Jack passed away in the year 2000. And then I was vice chair. And then in 2001, when I was vice chair, we had a change in leadership. And that's when my good friend Bill Colonie came, who is my good friend now, and we share a lot, but I didn't really know him before then. I was on the search committee, and we hired Bill, and then Bill and I worked very closely together. He is CEO, I is chairman of the board. And when Bill...
he's a very special person.
Bill. Oh, he is. He's a great guy, and I've learned a lot from him. We've learned a lot from each other. We've played a lot of bad golf together. But I have a great respect for Bill. And when Bill needed to leave the company in 2008, I had been board chair for 5 years, and I told the board that I was interested in coming inside as CEO and giving up practice, and they chose to support me to do that. And
here we are.
And I've had a ball, total ball.
That's terrific.
So.
So let's talk a little bit about CDPHP. It started out as a health maintenance organization.
Correct.
How long did it stay that way?
Well, it still
Solely.
is.
I know
right,
it's
right. It still is. So the parent is still the HMO, and it's a not-for-profit. But honestly, it existed as an HMO. We started to make the change around 2001. After we started looking at the company and what needed to change in the marketplace, we found that the HMO model was not popular with a lot of employers. They were looking for experience-rated. They were looking for more versatility in benefit design. The HMO, especially in New York State, is very heavily regulated, and employers wanted more versatility in benefit design. And so we were...
Is that due to cost concerns?
Due to rising costs. Because of rising costs, employers were looking to change benefit design. In an HMO, you're somewhat limited. And also, employers with good experience didn't want to stay in the community rated pool. And so we found ourselves in a position where some of the competition was starting to get into this experience rated or insurance business. And we knew that to survive, we needed to move in that way. So in 2001, we began to plan it. I will tell you that it really hasn't been until probably 2 or 3 years ago that we really started to gain significant membership in our experience-rated products. We have that in a company which is called Universal Benefits, which is wholly owned by CDPHP. It's called UBI, and that's where our experience-rated products are. And we predict that for the first time, our commercial membership, that is non-Medicare, non-Medicaid membership, of our UBI will be larger than our commercial membership of our HMO for the first time next year. So that we'll have, we're predicting, more members in the commercial membership UBI than in the HMO. So it was really, in terms of the corporate culture, in terms of the way we do business, it's only been within the last 3 or 4 years that CDPHP has, in a significant way, moved away from being a pure HMO.
So, how many members? Speaking of members, how many members do you have in the business, and how many members of those members? How many are in the Capital District? Yep.
Well, we have just about 400,000 members today, and I think today it stands at 398,000 or so, and we know that we'll pass the 400,000 member mark. Of those, about 290,000 or so will be commercial members, non-Medicare, Medicaid. We have about 30,000 or so Medicare members in Medicare Advantage, and we have the remainder, about 80,000 members in state programs, which is Medicaid, Child Health Plus, and Family Health Plus. As a not-for-profit community plan, we are committed to being in all lines of business, including the government business. Now, the majority of our membership is in the, we service 24 counties throughout the state, and so it ranges from, we go all the way down to Orange County in the lower Hudson Valley, and all the way up to the Lake Placid area and up there. And we do go west as far as Syracuse. But the majority of our membership is in, sometimes we call it our core 4, which is Albany, Schenectady, Rensselaer, and Saratoga. Then we add what I call the Suite 7 around that, and we get the core 11, which is the immediate counties surrounding that. And really that 11 county core is where
probably 80% of your business?
Oh yeah, 80 to 90% of our business. Okay. One of our biggest growth areas now has been in the Mid-Hudson Valley.
Poughkeepsie area?
Poughkeepsie area, Ulster, Dutchess County, where we're really starting to see some traction. We've also seen some great growth in the North Country, in Warren County. And of course, we're still very strong in Saratoga and Schenectady counties.
And it's pretty much all administered out of your headquarters on Washington Avenue?
Yep. It's all in our, we have about 1,000 employees in a 180,000 square foot building on Patroon Creek Boulevard, which is right off Washington Avenue. Yeah.
That's good.
Yep.
What is the big issues today, in your opinion, for the healthcare systems? I know, this is a presidential year. We've got people out there talking about Medicare in particular, the Affordable Health Care Act, and Obamacare, Romney Care. I mean, it seems like people are shooting out from here and going off this way, talking about different issues all the time. What's the reality when we're dealing with those things?
For me, with my experience as a provider, as a hospital board member in the past, now as the CEO of a not-for-profit health plan, and as a patient, I might add, I think the people that are screaming on the left and the people that are screaming on the right are both wrong in many, many areas. And I think the reality of it is that we have a healthcare system, or lack thereof, that is very fragmented, that is much too expensive for the...
How so fragmented when you say that? What do you mean?
It's fragmented because care is not coordinated in a meaningful way. Many medical practices exist in silos. They don't necessarily, at this point in time, have the technology to be able to coordinate care appropriately. And they're disjointed from some of the hospitals, even at which they work. They're disjointed from the payers, we have immense amounts of data which can help practitioners, but people can't get at the data, so there are technology issues. There's a problem with the reimbursement system. Our fee-for-service reimbursement system rewards volume, not value. It rewards quantity over quality, such that if you look at studies of quality and cost in America, we find that the areas that have the highest quality often have the lowest cost, and vice versa.
And what drives that?
Well, we think there are a number of drivers of high quality or low quality, high cost. One is unnecessary procedures and treatments. A lot of that we know now is driven by the wrong incentives, the fee-for-service system, which drives volume. When I was a cardiologist,
is there any defensive?
I think there's some of that.
Being
yeah, there is definitely some of that. But I think we really have to look at the fee-for-service system. So when I was a cardiologist, I got paid the more catheterizations I did, and the more echoes I did, and the more nuclear stress tests I did. Nobody ever paid me because I did a good job or not. In what profession do you have that? Now you can say that all doctors have to meet a minimum standard and they should all be high quality, but you never got paid by doing a good job for your patients. You got paid by doing more, and it's we talk about the volume value problem, that you can't just get paid for volume. You have to get paid for value. You mentioned the tort problem. That's clearly an issue. A lot of unnecessary things are being done because of defensive medicine. And what I like to say is that there are people that argue on both sides of that, obviously, and some people say there's some data which says it's a very small portion, and that's when you just look at the malpractice premiums doctors pay, which is a small percentage of the whole healthcare dial. Then there are, of course, some people that say, well, it's a very large part. The health economists that have looked at it really put it, as most things, somewhere. Reality is always somewhere in the middle, and it's a significant factor in leading to unnecessary testing. I think it needs to be addressed. I'm passionate about the need for tort reform in medicine. I don't think patients are benefiting from our system any more than doctors are. But it's one of the components. But I think the whole way we reimburse providers has got to change. And at CDPHP, we're moving ahead with that. We have a number of programs which are pushing that very aggressively. We're partnering with the CMS, the Center for Medicare Services. And there are a lot of features of payment reform in the Affordable Care Act, which are really going to benefit. They're set up as pilot programs, but they're really aimed at getting Medicare to kind of catch up to where the private payers are, because we're way ahead of Medicare on this. But a lot of it is about the payment system. If you look at America today and you look at graphs, there are so many areas where quality is low and cost is high. To me, that represents a tremendous opportunity. we can lower the cost of care as we improve the quality. And that's really what we want, because we need a lower cost of care because we can't afford the care we're getting, and we need a higher quality. So I think that's the hope that I find puts us in a good position today. People get very cynical and depressed and feel as though, we can't do anything about the problem. But if you can improve quality and lower cost at the same time, that's a tremendous position to be in.
Well, the average citizen sitting listening to the politicians screaming and yelling about their view, if you will, their side of the issue, really doesn't know where to go. What's the reality when we're talking about the current plan, which is the Affordable Care Act?
Mm-hmm.
Okay, is that a good deal as far as from the industry perspective? Do they see that as something that's going to be effective?
In many respects, yes. I think that the Affordable Care Act to me is a starting point.
Mm-hmm.
We have, right, the Affordable Care Act. I mean, I like to frame.
What's the good stuff about it? Let's talk about that.
So let's talk about that. So our problems in healthcare are quality, cost, and access, right?
Mm-hmm.
So the Affordable Care Act took care of some problems around access. It said we've got 50 million people in the wealthiest nation the world has ever seen. We got 50 million people without health insurance. That's not acceptable. So it said, what are we going to do about that? So it targeted some insurance reforms, which will tackle some of that. Right? It will reduce that. They created the exchanges, et cetera, and some subsidies. And you can argue about, and there's a lot of debate about, the cost. Well, of course it's going to cost more, okay? In my view, you're going to be now providing care to people. So on that side of the balance sheet, it's going to cost more. But the flip side is that if you can get these people without insurance, if you can get them the preventive care, the investment in that will lower the cost down the road. And we're seeing that every day on a small level at CDPHP. Once we get these underprivileged people care and we start to give them preventive care, that we know that their costs can go down. So it dealt with access right away. What it also needs to deal with, and does deal with, are some of the cost issues. There, as I alluded to, there are pilot programs going on which look at paying physicians differently. And this region was chosen largely because of a lot of the work that CDPHP has done to participate with 6 other regions in the country in a new payment mechanism with Medicare and the private payers to try and change the incentives. So the providers are incented for value, not for volume. So we need to address the cost issue. We need to address the quality issue by, again, advancing evidence-based medicine, by doing comparative effectiveness research, which has been, vilified by some people. As, there are few things that get me angrier than the word death panels. There are no death panels in the Affordable Care Act. There are no death panels in the Affordable Care Act. There is monies towards to be put towards comparative effectiveness research, which is to look at the effectiveness of treatments. Don't you want your treatment to be effective? Of course, from a medical standpoint as well as from a cost effectiveness standpoint. It's something as a society that we have to deal with. There's no rationing in the Affordable Care Act any more than there's rationing today. I mean, every economic system rations something. Today, people are not getting health care because they cannot afford it. That is the marketplace creating rationing. So I see a lot of those good things in the Affordable Care Act. Are there things in it?
Some people claim that everybody's got health care because if you don't have it yourself, you just go to the hospital and you're part of the Medicaid system as opposed to the regular.
Well, you have to remember that you're not, because a lot of states, and remember, the other thing that this debate has afforded me the opportunity to reflect on is it's kind of nice being in New York because we kind of try and take care of our people in New York. We do provide Medicaid benefits, to the poor. Some states provide far less, but in many states, if you remember, New York State provides Medicare benefits to people up to 130% of the federal poverty level. Many states, it's way below that. So not everyone is eligible for Medicaid. There are gaps. There still will be gaps even after the Affordable Care Act. And we could argue a lot about, you know, I mean, it's very expensive, and can government afford it, and how's it going to do that? But, and so New York State is more generous than a lot of states, which, you know, that's one of the reasons why the effect of the Affordable Care Act in New York State will be vastly different than it will be in a state like Texas, where 25% of the population is uninsured, 25% and climbing. In New York State, it's 11%. So, and then
a lot of people.
It's a lot of people, and that's one. Can you imagine 1 in 4 of your citizens don't have health insurance? Don't you think that's a problem? I mean, I think that's a real. I think 1 in 6 is a problem. 1 in 7 is a problem. Actually, it's 1 in 8 in New York State is a problem, but 1 in 4. That's no matter what side of the aisle you're on, you have to say that's a problem. We have to solve that problem. Now, the Affordable Care Act is an attempt at doing it. And, you know, there are problems with the Affordable Care Act, many. I mean, what are we going to do with the exchanges? Who's going to be in them? Are we going to create adverse selection for the health plans that are in the exchange?
Explain adverse selection. I think that's a good term.
So adverse selection is if you offer very rich benefits to people that have never had health care, then you're going to get all the sick people in. You have to remember that the social compact of insurance, to some extent, is the well paying for the sick. So when you're young and healthy, we call them the young 30-year-olds. We call them the invincibles, the young immortals.
No, right? A lot. Was one once.
So, right. So when I was 30, I didn't think I was ever going to get sick,
yeah.
right? I was never going to die. I was never going to get sick. So why was I paying for insurance? I didn't need it. I thought I didn't need it. Now, I could have got run over by a truck, in which case I would need it, but you don't think of that either.
Trucks and buses, right?
Right. So, but that's what insurance is, right? It's the healthy paying for the sick, to some extent. We have to moderate that, and that's what the insurance industry does. It tries to apportion that risk, make that risk for the young affordable, so that they can help pay for the sicker population. But that's the social compact of insurance. But adverse selection occurs when you have a benefit design or a reimbursement scheme that means you only have the sick people in the pool. And if you only have the sick people in the pool, that's a real problem.
You're going to fail.
You're going to fail. It's too expensive. And that's why the individual market in insurance in New York State is so expensive. There was a piece today in, I forget where, one of the news wires that I read every morning came across where it talked about the rate for individual insurance in New York State, in New York City, is $100,000 a year. It's nuts. That's because the only people in that pool are the very, very sick. So you need to support that pool with all the other people. To me, that's
spreading the risk.
That's what insurance is all about, and people don't understand that. So, getting back to the exchange, we have to be careful that the exchange isn't full of just the sick people, and that people can't only get in when they're sick. In other words, that would be like, I have car insurance, but I don't get it until I have an accident. And then I go to the insurance company and I say, oh, you have to insure me, because but now I've had an accident, right? That's the worst thing. So you have to have some rules, right? People have to maybe only enroll once a year, or it has to be mandatory. And then we get to this whole political fight over whether the mandate, what's the role of the mandate? Well, if the healthy people don't have to be in the pool,
they won't be in the pool.
Then some of them won't be in the pool, and you won't get their dollars to help support the other people. I mean, that's what a collective society is kind of all about. So a lot of people don't, whether you agree with the mandate or not, first you have to understand what it does. And from an insurance perspective, having the mandate makes the pool much safer from a standpoint of adverse selection.
Okay. I'm glad you explained that, because I think that
I hope that's clear.
But that's technically
take the emotion out of it.
Right.
Just
it makes the plan work.
Look at the math. Okay, the mandate makes the plan work. Now, I would argue that the mandate wasn't strong enough. And if you look at the Massachusetts experience, the mandate started out small, and then they grew it. It was even bigger. If you go to Massachusetts, people aren't complaining. They're pretty happy. And very few people have been fined, and they've covered all their citizens.
Romney Care.
It's Romney Care. Romney created it, and it's in my view, it's working pretty good. And now, of course, but that's politics. I mean, now, of course, he's got to deny it so that he can gain the support of people on the right. which
Probably the largest percentage of money being spent on health care is for seniors, I would assume, that people over 65, Medicare and other programs.
sure.
How does that affect the rest of society? Because I think there's, I mean, I don't even know what the percentage is, but I think it's substantial in terms of cost of
the cost of the elderly
caring for the elderly.
is more expensive because the older you get, the more likely you are to be sick, right? So if you look at the cost of care on a per member, per month basis, so what a health plan will pay for health care for someone over 65 versus someone under, it's 3 or 4 times.
Mm-hmm.
I mean, that's the fact. Older people cost more, right? Everybody knows that. And our society is aging, and that's another stress. And so, I mean, currently, how do we deal with that? Well, we pay taxes. I mean, everybody pays a Medicare tax. But from an insurance perspective, we know that the over 65 crowd, I mean, we know what the PMPM is, the per member per month cost, and it's 3 to 4 times of what the people under 65 is.
So, and you're dealing with this with the Medicare level. I know that you've got a number of plans that not only deal with Medicare, where you provide the administration for Medicare, as I'm assuming that's what it amounts to, right?
Well, it's more than that so I could explain Medicare. So traditional Medicare fee-for-service,
Mm-hmm.
the government pays the bills, although they don't really pay the bills. They give the money to a third-party administrator who then pays all the claims.
The CCM?
It's like a TPA. It's a third-party administrator. And they often pick they usually pick the big for-profits to do that, or some of the big blue plans. And they just pay the claims throughout several states. And I get a kick out of it because the government claims they have a very efficient system and they have a lower admin overhead. And it angers me because I think they're doing the math wrong, because they're not counting all the other costs that they're offloading to the carrier. And they're also not, when they do a percentage of admin overhead, they're not counting the fact that their denominator is a lot greater. So their actual overhead per enrollee in Medicare is a lot higher than their overhead per enrollee on the commercial side.
Okay.
But that's a sleight of hand. But what they do is, so the government doesn't pay any claims. It gives the money to whatever, a carrier. The CDPHP doesn't get involved in that business. And in the fee-for-service side, there's no care management. So in the Medicare Advantage plan that we have, for instance, for our Medicare seniors, which is a little over 30,000 now, people, we do care management. We take care of the people. So if you're a Medicare CDPHP, and there are other health plans, we're not the only one who plays in this space, obviously. If you need help facilitating care, getting a certain specialist, doing something, you get that care. You get that help doing that, and at a price point that is very, very affordable to the consumer. Consumers love Medicare Advantage. One of the first things I did when my mother moved from New Jersey here was get her Medicare Advantage. I mean, it's a tremendous plan. So consumers love it. And not only that.
Consumer friendly, or is it the results are better?
Both. So for instance, if you look at quality in terms of, and you look at efficiency, Medicare Advantage plans, the top Medicare Advantage plans, the 4 and 4.5 and 5-star plans, the CDPHP is a 4.5-star to 5-star plan. The quality scores compared to the Medicare fee-for-service side are higher. Our readmission rates are lower. We have data to show through a group of other regional not-for-profit health plans throughout the country that our readmission rates for our Medicare subscribers are half that of the fee-for-service population, because we coordinate the care. We coordinate the care. We send people into the homes. We send our case managers into the medical practices to work with the doctors to take care of the people. Medicare fee-for-service, right now, you don't get any of that. That's why they're doing this pilot in this region to try and do what we're doing in their Medicare fee-for-service side.
So
that's
Advantage plan is part of the pilot program?
Well, they're actually going to do what we already do in the Medicare Advantage side in the fee-for-service side. And so that's where I get angry at the left and the political spectrum, because those are the people that are saying that the Medicare Advantage is just insurance companies taking a lot of profit. Well, we're providing real care management services that they now are trying to duplicate on the fee-for-service side to do what we do. And they're coming to us saying, CDPHP, show us how you do it. We want to do it on the fee-for-service side. And then the politicians are screaming that it's just Medicare Advantage is just insurance companies making a lot of profit. So that shows you where I get angry at both sides, and you want to butt their heads together and say, look, we can solve this problem. Stop the nonsense. You stop the nonsense on the left. You stop the nonsense on the right. Let's have a rational discussion and solve the problem. But that's an example of it.
Well, having experienced the Advantage plan with my wife's mother, it was just a marvelous experience for her through the time that she died. But people
love it.
It was just
it's a good
a
economic deal
program
for them too. It's a good economic deal.
Yeah. When we talk about cost, and this is the last thing I really would like to get into, if we're talking about costs of programs, are the costs driven by the claims the insurance companies have? Are they driven by the hospitals? Where are these expenses? Because everybody who participates and pay premiums for health insurance,
right,
either the employer or a proportionate pro rata basis for employees,
right,
know that the costs have skyrocketed over the years.
Right.
And what, in your opinion, is the main precipitator of that?
Well, we have to remember that the cost of insurance premiums does nothing other than reflect the cost of health care. Mm-hmm. The net margin, if you will, operating margin of health plans, certainly of not-for-profits, around the country is on the 2% average. And that's margin that's created to reinvest capital in the business. Mm-hmm. But the net margin is 2%. The overheads range from 8 to 11% in general. I can tell you that since 1996, the overhead at CDPHP has ranged from 8 to 11%. So
overhead being mostly administrative costs,
salaries, equipment, technology, et cetera. So, and if you look at the rise of rate of the administrative costs, they have been dwarfed by the rate of rise of the healthcare costs. So the healthcare costs continue to escalate. Hospital costs over the last decade have just ballooned. We're very worried about hospital consolidation. The other thing people have to understand is that...
Won't that effectively lower the cost of...
If they can do the job right. But what you have to understand is hospital consolidation can lead to, and has in most markets, higher prices.
Why would that be?
Because what people have to remember is that the insurers are the buyer of services. So we're the buyer of hospital services for the consumer. We mm-hmm. buy the services of the hospital on the consumer's behalf.
All right.
And so we're trying to get the lowest price we can. The hospital is the seller.
Okay.
So when you have seller consolidation, traditional economic states that you have higher prices. When you have and in fact, if you look at the data, that's what it shows. That's what it shows. You have a lot of markets that are very consolidated in terms of hospitals, and when they use that market power to get higher rates, even with the best of intentions, thinking that they want to build a new building because the community wants it, or that and these are even not-for-profit institutions. They've got the best of intentions. They want to build a new building because the hospital wants a new building in its community because it's nice. They want to get the latest and greatest technology. Remember, even though we may not have evaluated whether that technology is even good, but it's the latest and greatest. So they have all the best intentions, but to do those things, they need more money, and so the price is driven up because they can negotiate now from a greater strength. In this market, you have cities which have one hospital system, and so you need those hospital systems to do business, but yet you have 4 or 5 insurers competing for that business. And most communities in America are like that. So we're very concerned that hospital consolidation can lead to higher unit prices and higher utilization, even though they have the best intentions.
So especially when we're dealing with technology, things like that, I know that technology is
Yep.
Everybody likes to have the cutting edge technology, especially if you're going to go do it. Is it always necessary?
No, it's not. Sometimes it's necessary, and we started off our talk by me talking about the great advances in cardiology, and certainly a lot of those were technologic ones, but there are many technological things that turn out to have no value add. Or they're done on the wrong people. Or they're done by operators, surgeons, and procedural-oriented physicians who don't do enough procedures to make them truly good at it. There are many, many lessons learned about the overuse of technology in medicine, and many sad stories to tell, as well as the wonderful stories about all the great stuff we do. We just have to be able to have a rational conversation about what's the right thing. And that's why one of my hopes is to provide for some meaningful community health planning in the capital region. I think we have a tremendous opportunity to do that. We have great institutions. We have great hospital institutions. We have, I think we have great not-for-profit payers. We have a community which wants to come together around economic development. And we ought to be able to construct some kind of meaningful community health planning.
Have you made any efforts in that way to contact various segments of the healthcare community? And I think back to WMHT used to have annual programs on where they would bring segments of the community in, leaders of the community. I think Ed Dagg used to lead them, and also the Rex, can't think of the last name, who was with the Times Union. The editor or publisher there, he used to come in and lead some of these conversations. Has there been an effort by you or by other people within the healthcare community to try to bring some of that out so that the public would be able to deal with some of it, or listen to people dealing with some of the issues and get a feel for both sides of the issue?
Yeah. Well, I've been very involved with organizations like the Albany Colonie Regional Chamber of Commerce. I've been involved at the Center for Economic Growth. I've been in discussions with the Governor's Regional Economic Development Council about finding ways to do community health planning. I've been in active discussions with the leadership of the major hospital systems, Albany Medical Center, St. Peter's Health Partners, Ellis, to really come together and find a way to talk about community health planning, to really look at how we can improve the quality of healthcare in this region. We have another great resource in the area, that's the SUNY School of Public Health, which has done some great work in terms of quality reporting and quality advancement, and I think we need to build on that. We're starting a lecture series around quality, cost, and access, and the SUNY School of Public Health is going to do this lecture series, and they're going to bring Dr. Atul Gawande to Albany on January 16th.
Does he write for the New Yorker or something?
He wrote some very great articles for the New Yorker on quality and cost and access in healthcare in America. He's got a lot of great ideas, and we really want to use him as a focal point to start the discussion. And CDPHP is going to be part of that discussion that's going to be hosted by the SUNY School of Public Health in January. We're very, very excited about that as a way to begin one of many other efforts to begin a discussion around how we can make quality, affordable health care in the capital region and move it to the next level.
Quality is an important thing, and I think having the state university and whatever schools in the area, you mentioned you went to RPI, and certainly Sienna's involved, and there's other schools in this area. It's just terrific that everybody is at least talking to each other.
Right.
And I think that bodes well for the community.
Right.
And speaking of that, as we've gone on, we could go on for probably hours more talking about a lot of the issues we've discussed, but we can't here. So perhaps some other time we can come back and get together and update ourselves. But I want to thank you very much for coming and speaking to us, and I want to thank the people who may take the time to listen to what we've talked about. I think that you're probably better informed now that Dr. John Bennett has been here talking about the important issues relating to healthcare, relating to the things that we deal with, and certainly we're glad that you were able to join us today. And we look forward to the next time when we get together. This is Jack Mulvey signing off for Capital Community, and look forward to seeing you again. Thank you.